So one of the things you always need to think about when you're doing a breast biopsy is where the lesion is relative to the chest wall. Obviously what you don't want to do is cause a pneumothorax. Now if you have a lesion that's in the center of the breast here, that's pretty straightforward. You can get a pretty nice target through this lesion. Don't forget that most needles have about a 2 centimeter throw on them, and you're not at risk of biopsying the lung or the chest wall in any way here. But if you have a lesion that's back here, then you're going to have to be much more careful with your target. If you came down at the same angle here as you did with the other lesion, you're probably going to get at least pectoralis, and if you weren't careful, particularly with even more posterior lesion, you're going to go into lung. So with the deeper lesions, particularly in patients who have larger breasts, you're going to have to come at a very horizontal angle to be able to have safe deployment of that needle. So we always want to be thinking 2 centimeters beyond our needle when we're deciding what angle we want to come in at. We need to be at an angle that will allow us to be able to see the needle adequately. Don't forget, if the angle between your transducer and your needle is more than about 45 degrees, then you're going to have trouble being able to see that needle well. But on the other hand, you don't want to be so shallow that you risk actually coming through the skin on the other side of the breast. Now sometimes for these deeper lesions, I will do what I call an L-shaped path. And what I do in this situation is I pop the needle just a little bit through the skin, just maybe down 1 centimeter or so. Then I lever it down in a more horizontal pathway. This is kind of it's almost like a backwards L here. And I'm going to use that to approach it. And what this enables you to do is you can come into the skin much closer to the lesion than if you were having to come perhaps on the other side of the breast like this. So I might do it from here. I'm going to come down 1 centimeter or two, then move my needle down to a more horizontal position and come into the lesion like that. So one of the tricks of trying to get at a deep lesion safely is that you want to be as close to parallel to the chest wall as possible. And so what I do in these circumstances, I do what's called an L-shaped path. And so my cannula is going to go at a very steep angle for about 1 to 2 centimeters, and then I lever the cannula horizontally and slide in so that you're almost parallel to the chest wall here. Now you need to do this with a fair amount of care within a patient, and so usually what I do, if you can demonstrate for me, Nicole, is perhaps you can do it further in the beef, so we have some beef, is prop the fingers of my hand at a place so I can't push, there we go, too deeply with that initial insertion of the needle. If you're just doing it, sort of holding on to the end of the cannula, then it's possible to pop that in too deep. And that's a very effective way of getting deeper while still being at a good imaging angle. So this is just showing how you do this. So she's going to pop down fairly steep, that first part of the needle, and then lever horizontally to slide along. You can see you can get much deeper in the breast tissue using that technique. But again, just take great care on that initial advancement for just 1 centimeter or 2.